Thank you. Thank you, Paul, for the introduction. And yeah, I really enjoyed being in Utah. It's a beautiful state. You guys are super lucky to be here. Um, so what I want to tell you about, What I want to tell you about today is give you an overview of visual cycle modulation, this therapeutic concept. And I think it's kind of relevant. I know a lot of the clinical trials, or at least some of the clinical trials around this concept have been the Moran Eye Center has been a site for these. So I thought it'd be interesting to sort of review what the state of the art is in this area, and then kind of end with some of our efforts to improve visual cycle modulation to make it more tolerable for patients. Okay. Just one disclosure that I'm a co-founder of a company, Isomer Therapeutics. It's very much a initial stages, but basically we have formed this company in order to get STTR funding to promote some of the studies that I'll tell you about at the end of this presentation. Okay, so this is the outline. I kind of want to give you an overview of the visual cycle. I know I'm in an ophthalmology department, so I don't need to cover this too extensively, but I will cover a little bit more about some of the new developments in the visual cycle and some of the alternative pathways for 11-cis retinal regeneration. And then discuss the involvement of the classical visual cycle in retinal diseases, and then review some of the therapeutic strategies that are being pursued to therapeutically modulate the visual cycle, and then at the end outline some of the strategies we're employing to create better tolerated visual cycle modulators. Okay, so again, this is all going to be familiar to you at the beginning. Where we're focused on for this talk is the back of the eye and the retina, where the primary photochemistry of vision is taking place in the rod and cone photoreceptors. This is where light's absorbed and converted into an electrochemical signal. And the way this works is that whenever a photon is focused onto the photoreceptors, it's absorbed by this 11-cis retinaldehyde chromophore that's bound to the visual opsins. And when that light absorption process happens, it induces a photoisomerization from the 11-cis configuration to the all-trans configuration. And that leads to this change in the conformation of the visual pigment. And it's that change in conformation that allows it to couple to its G protein to initiate phototransduction. Okay, so at the end of this video, I kind of show this again, and the chromophore is gone. And that's not by accident. Our visual pigments, vertebrate visual pigments, are bleaching, meaning that at the end of the photoactivation process, they release the retinaldehyde chromophore, and that needs to be regenerated so that vision can continue. And just a little bit about the history of this, investigations into how that regeneration happens. Actually, these investigations were initiated about 150 years ago by two physiologists in Germany, Bull and Kuhne. And it was Bull who really first observed that upon taking a retina out of a frog eye and exposing it to light, that undergoes this series of color changes from red to sort of yellowish, and then eventually becoming colorless. And he was the one who hypothesized that it was this bleaching process, which is actually underlying the visual process. And so Kuhne, another physiologist, kind of took this a step further and found that if you took this bleached retina and put it back onto the eye cup and placed it back in the dark, that it would regenerate it would regenerate its color. Okay, they didn't know anything about the chemistry of this process at the time. And if you're sort of interested in this, Harold Ripps had a nice review on this in FASIB Journal a few years ago. And really, this is where the work stopped until George Wald picked it back up and discovered that really what was happening here were this series of transformations of vitamin A derivatives that were giving rise to these color changes. And he was awarded the Nobel Prize for that work in 1967. And so today we know quite a bit more about the visual cycle. Really, the classical visual cycle is understood in a great amount of detail. The process I just told you about, this isomerization, is described here, 11-cis to all-trans. It releases the chromophore. And there's an initial processing that happens in the photoreceptor outer segments, but then this reduction from retinaldehyde to retinol. But then once you have the retinol, that's actually transported to the retinal pigment epithelium. And this is where most of the visual cycle is happening. And I'm not going to go through these steps in a lot of detail, just point out two of the most critical ones, LRAT and RP65. LRAT's making the substrate for RP65 is an all-trans retinal ester, and RP65 is isomerizing that. And it's really, this is the hallmark step of the visual cycle where you have a trans retinoid becoming a cis retinoid, and that can occur in the dark. Finally, this is oxidized and then brought back to the photoreceptor to regenerate a ground state visual pigment. Okay, so this is like the base kind of classical visual cycle, and this is where I kind of wanted to give you a little bit of an update on what's been learned in the last several years. This is, again, what I just described to you, the classical visual cycle, but we now know there's a lot of other pathways where you can get it, by which you can get 11-cis retinaldehyde. One of these involves a protein RGR. So this is the retinal RPE G protein coupled receptor. It's a misnomer, actually. This is not a G protein coupled receptor. It's a photoisomerase. And it takes all trans retinal and uses light to transform the trans retinoid into a cis retinoid. So that's one pathway. So that was something actually that was discovered several years ago by Henry Fong's group at USC, and it kind of fell out of favor and then was recently picked back up, and is kind of now, I think the consensus in the field is that this is a physiologically relevant regeneration pathway. There's also pathways that don't involve enzymes, formation of NRET-PE, which can then be photoisomerized to give 11-cis retinal. And then beyond this, there's pathways in the Mueller glia as well. So only some of these are understood. For example, RGR can also function in the Mueller glia to generate 11-cis retinal. And it's really in this 11-cis retinal is thought to be selectively channeled to the cones instead of the rods. Now, despite all of these different regeneration pathways, it's important to point out that you have to ask yourself, we know like in LRAT or RP65 associated retinopathies that there's a lack of visual chromophore. And so the question is, why can't these other pathways pick up the slack? And really the reason for this is if you lose LRAT, you can't get retinoids into the retina, period. And if you lose RP65, any of the retinoids that get there get trapped as retinal esters. So they're really not available for these other pathways. So that's kind of how I think about why it is that all of these pathways are so critical on the classical visual cycle. Okay. So let me kind of now talk a little bit about the whole concept of visual cycle modulation. And Dr. Bernstein already mentioned this. I'm not giving away your age or anything here. So this is work from Paul Bernstein whenever he was working with Robert Rando at Harvard during his PhD. And what they found was it was known that some aromatic amines are retinotoxic, and they had done an investigation into why that's the case. What they found was that certain aromatic amines block the regeneration of rhodopsin. I believe this was in a frog model. And not only that, they could also block the formation of 11-cis retinal palmitate, again at 24 hours. And through some additional studies, that it was discovered that the way this is happening is these aromatic amines can actually form a conjugate with retinaldehyde called a Schiff base, forming this structure, which then is susceptible to photoisomerization. So it's basically making this 11-cis more prone to non-productively isomerize to the all-trans configuration. And that's the mechanism by which this effect was exerted. And so that was in, again, note the date, 1986. And there was something in the air in 1986 because there were some other investigations with two compounds actually studying the side effects of two drugs, isotretinoin, which is used to treat acne, and then fenretinide, which is an investigational agent used to treat cancers. And what was found in these investigations was that these compounds can suppress ERG function. You can see during treatment, particularly in the scotopic ERGs, during treatment, they're suppressed. After the drug washes out, it comes back. And that was also true for fenretinide, suppressed, and then coming back after the drug washes out. So this was really an important origin or kind of discoveries that you could actually modulate the visual cycle with small molecule compounds, either with direct reactivity with retinaldehyde or by somehow affecting some process of the visual cycle. And that's what they were hypothesizing in these papers, that these compounds were affecting the visual cycle. So we have these compounds. So what then the other kind of aspect to this is, what effect would inhibiting the visual cycle have on disease processes, or what disease processes is the visual cycle relevant to? And two, where it seems to be clearly relevant, is a disease called Stargardt macular dystrophy, and then also AMD, or geographic atrophy, where you can see in these fundus images, there's this kind of autofluorescent material that accumulates around these central lesions. And this is bisretinoid, okay, lipofuscin, which is composed of bisretinoid. Bisretinoid comes from the visual cycle. So whenever all-trans retinal is produced, it can react with phosphatidylethanolamine. And that's actually a normal process. And most of the time that's reversed and the retinoid goes ahead and goes into the visual cycle. But under some cases, this can progress further and form these fluorescent and toxic bisretinoid compounds such as A2E. And that's what this fluorescence is representing. So then the final piece of this is observations in the RP65 knockout mouse. So this is where the visual cycle is completely knocked out. In a wild type mouse, they also accumulate bisretinoids, but it was observed in the RP65 knockout mouse that these bisretinoids are pretty much completely absent. So that really led to the hypothesis that if you could suppress the visual cycle to some extent, it's obviously a fine balance because we need this to see, but if you can suppress it to some extent, you might be able to slow the formation of these bisretinoids, and then slow the progression of these diseases. And this was tested really for the first time by Paul Sieving. This was in the early 2000s, where they did this experiment using 13-cis-retinoic acid, or isotretinoin, as I had mentioned earlier, and showed that indeed in mice, isotretinoin can suppress ERG function, both in terms of rod function and cone function, and that this compound can protect against light-induced retinal degeneration. So this is the no light control. This is treated with isotretinoin, and this is the vehicle treated. You can see that you have a nice preservation of the outer nuclear layer in the drug-treated animals. Okay. And then finally, this was taken a step further and tested in a mouse model of Stargardt disease. Just as a quick reminder of what Stargardt disease is, in the normal situation, well, first of all, Stargardt disease is due to a mutation in ABCA4. So let me just quickly review what ABCA4 does. After rhodopsin is bleached and it gives up its all-trans retinal, this could actually be released into the outer leaflet of the bilayer or the inner leaflet. And if it's in the inner leaflet, it actually can't get access to the RDH, the enzyme that reduces it to allow it to go to the retinal pigment epithelium. And so in order to get this retinoid from the inner leaflet to the outer leaflet, that process relies on ABCA4. So it's a flipase that flips the retinoid to the outer leaflet, and there this can dissociate and be metabolized by RDH8, okay, to enter the visual cycle. So if you don't have ABCA4 functioning, that process doesn't happen. And so these retinoids persist in the inner leaflet and are prone to then progressing to form bisretinoid addicts, which then can cause retinal toxicity. So in this study, they used a mouse model where ABCA4 was knocked out. And what you observe in this mouse model is the accumulation of A2E, like is observed in Stargardt patients, and that's indicated by these red arrows, these little inclusions you can see in these electron micrographs. And what was noticed is whenever you treat with isotretinoin, that those bisretinoid or lipofuscin aggregates are much reduced. And this was quantified by HPLC. This is the precursor to A2E, as well as A2E level, as you can see in the 4-month-old treated with isotretinoin, that these levels are much, much lower. Okay, so that kind of brings this concept again, that especially for Stargardt disease, that this could be a very effective therapy to prevent disease progression. Okay. So this, I just kind of outlined here the diseases that where visual cyclomodulation may benefit. Okay, so Stargardt disease, I think, is the most clear-cut case, as I just described. AMD, possibly. So the early stages of RP cell death or cell dysfunction, I would say, are often linked to lipofuscin. So again, if you can inhibit the visual cycle, you might be able to slow that down. Things like light damage, visual cyclomodulators clearly protect against light damage, and potentially under some clinical conditions where maybe the eye has to be exposed to light for a long time. This might be something that you could use. These visual cyclomodulators might be able to prevent this damage. And then there's others that are kind of more recent things that have been discovered, certain forms of retinitis pigmentosa, for example. And then finally, diseases associated with photoreceptor metabolism, so diabetic retinopathy, retinopathy of prematurity, potentially even ischemic retinopathy. So the way that I kind of think about this concept, or the terminology we've proposed, there's really two different strategies that you could think of. There's an extrinsic strategy where the goal is to reduce delivery of retinol to the RPE, or an intrinsic strategy where you're trying to modify the function of an enzyme or retinoid binding protein within the visual cycle proper. And I kind of have these outlined here. So extrinsic agents, extrinsically acting agents would be things like fenretinide or tinlarebant. I'll talk about both of these later. And really, they're targeting retinol binding protein 4. So this is the key protein that's responsible for getting retinoids to the retina. Or you can think about agents that can, again, act within the visual cycle proper, like a mixostat or, again, 13-cis-retinoic acid. So I'll kind of go through these one at a time. Sorry, the text. Okay, yeah, the font got changed a little bit, so sorry, my animation didn't work perfect. Okay, so let's start with extrinsic visual cycle modulation, and basically this is RBP4 antagonism. The pharmacologic goal here is to reduce RBP4 mediated delivery of retinol to the RPE. And the mechanisms here there's multiple mechanisms. It involves blockade of whole RBP4 secretion from hepatocytes or inhibition of TTR interaction. So normally, the way that RBP4 circulates in the blood, or whole RBP4, is in complex with TTR, transthyretin. And this interaction is important. RBP4 is a small protein, so it's easily filtered across the glomerulus. So you need this interaction to keep it within the circulation. And a lot of these RBP4 antagonists prevent this interaction. So the RBP4 ends up being lost to a greater extent by renal clearance. So the agents here I'll talk about are fenretinide, A1120, thank you. A1120, tinlarebant, and then this other compound, STG001, which we don't know much about, but it's something I think that may still be in clinical investigation. Again, so what normally happens, we have RBP4 circulating with TTR. It passes through the vasculature and interacts with the protein STRA6. This is the retinol channel. It allows retinol to pass into the RPE where it interacts with CRBP, which brings it to these enzymes of the visual cycle. Okay, so this is kind of an older study from 1992, just showing what fenretinide is doing. So this kind of explains, I showed you the ERG suppression earlier. This provides a molecular explanation for that. So whenever they treated, these were rats with fenretinide, what you can see is that the levels of serum vitamin A go down, as well as the levels of serum RBP4 compared to the vehicle treatment. So again, the mechanism here is by depleting RBP4 within the serum, and that's reducing vitamin A delivery to the RPE. Oh. Okay, so molecularly, we understand a lot about how fenretinide works. This is the structure of RBP4 in complex with all-trans retinol. This is the same structure, but this is in complex with TTR. I'm only showing part of the TTR molecule here. And this is the structure of RBP4 in complex with fenretinide. And so what you can appreciate, and I kind of have this zoomed image here, is that this ring structure that's kind of foreign or different compared to all trans retinol, kind of sticks out further from the binding pocket. And you can see where TTR would normally reside, there would be a steric clash with this bulky ring. And so that's what prevents this RBP4 TTR interaction, and what leads to the RBP4 being lost in the kidney. Okay. So this is, I'll say this again. So fenretinide, again, it's not an FDA-approved agent. It's been studied for a lot of different cancers, and it's also been studied in age-related macular degeneration. But in general, in drug design, you want to stay away from retinoids. They're teratogenic, and they have a lot of other kind of not favorable properties. So there was an effort to develop RBP4 antagonists that were non-retinoid. And the first of these was this compound A1120, which was developed by Amgen. This was actually, the purpose of this originally was for metabolic syndrome. So there was a point where RBP4 was implicated in metabolic syndrome, and they were trying to find antagonists to treat that condition. That kind of turned out not to pan out very well, but this was a good lead molecule for new RBP4 antagonists. And so that was picked up by Costa Petruchin's lab at Columbia University, and they developed a series of molecules here. You can kind of appreciate there's some similarity. You see this sort of CF3 group, which is common to all of these, with various substituents here. But this kind of culminated in the development of this molecule called tinlarebant, which is currently in clinical trials, so I'll discuss in a little bit of time. There's another compound, which again is related. We don't know much about this one, called STG-001, but this is kind of the current state of the art in terms of RBP4 antagonism. Now, going back to A1120, just real quickly, we also know how that one binds to RBP4, and it turns out it doesn't have the same steric interaction with TTR, but instead the way it works is by altering the conformations of these loops, this beta-3, beta-4, and beta-4, beta-5 loop, which are important for the TTR interaction. So by disrupting this, that's another mechanism by which you can break down the RBP4 TTR interaction. Okay. So there's been one published clinical trial on these RBP4 antagonists. This was with fenretinide. This was published in 2013 by Mehta et al. And like what was observed in rats, treatment with fenretinide causes a dose-dependent reduction in RBP4 levels. And whenever you look at and this was being studied in GA, compared to placebo, you can see that there wasn't, if you look at the full data set, there wasn't any statistically significant change in the lesion growth rate. But there was a trend whenever they looked at the individuals that achieved the lowest levels of RBP4, there was a stronger correlation here between the RBP4 level and the lesion growth. Again, it wasn't statistically significant, but there was a trend. And then finally, they saw a reduced probability of progression to choroidal neovascularization. Or again, this wasn't statistically significant. So there was a little bit of a hint here that this strategy was working, but it kind of needed to be followed up. But again, this fenretinide was sort of abandoned again because of its retinoid properties. Okay, so that's on the extrinsic side. Now I'm going to move to the intrinsic side, where we're modulating enzymes of the visual cycle, and this is where we've done most of our work targeting RP65. So again, with intrinsic visual cycle modulation, the goal is to slow 11-cis retinal generation. And so the mechanisms here would involve, say, inhibition of enzymes involved in retinoid cycle metabolism, or inhibiting retinoid binding proteins. So we don't only have retinoid binding proteins outside in the vasculature, but there's also retinoid binding proteins within the visual cycle proper, which are important for getting retinoids from one membrane to another. So the agents here would be RP65 inhibitors, CRBP1 inhibitors, for example. I'm going to focus mainly on the RP65 inhibitors, retinylamine and amixistat. Okay. So this retinylamine actually was developed based on a hypothesis of how RP65 works. If you look at how RP65 could function. One of the ways is by producing a retinal cation intermediate, which allows the reduced bond order that's needed to go from trans to cis. So this was sort of this putative transition state of RP65. Based off this hypothesis, this molecule, retinolamine, was generated where there's this amine group, instead of having hydroxyl at the end like in retinol, there's an amine group which is positively charged, and the idea was that this was going to mimic this retinal cation intermediate and therefore inhibit RP65. And in fact, this idea worked very well. This is a mouse model. This is pre-bleach treated with all-trans retinolamine, and then this is after a photo bleach. Here's the ERGs. You can see it's normal here. After the bleach, 5 hours, the ERGs are very largely suppressed, and it stays suppressed for a long time. Even at 24 hours, the ERGs haven't recovered very significantly compared to the control value. So this was definitely and I'm not showing, there's a whole lot of other data showing that this works in vitro as well, but clearly it works very well in vivo. It's a very long-acting compound. So again, just like with fenretinide, there was an effort to get away from this retinoid-like structure. So this was taken and further developed by a company called Acusella into this molecule, amixistat. And although, it's hard, it might be hard to appreciate that this molecule is related to this one, if you actually overlay the carbons on top of each other, you can see that the connectivity is very well preserved here. So it's clear that this molecule was derived from retinolamine. So this was, we actually directly head-to-head tested these compounds to see how much better amixistat was compared to retinolamine. And in fact, it's significantly better. So this is in vitro RP65 inhibition. You can see it's inhibiting much lower concentrations compared to retinolamine. And also in vivo, it works much better in terms of suppressing visual cycle function. So we studied this further. Again, we did some crystallography and figured out where this compound was binding within the RP65 active site. The RP65 active site's like a cul-de-sac. There's kind of an inner chamber and an outer chamber, and we found that amixistat's binding in this outer chamber. And this was interesting not only for figuring out how this compound's working, but it also helped us to reveal some of the catalytic properties of RP65. So it was kind of it was a kind of had a dual function, and we published this a few years ago. And we've done very extensive medicinal chemistry on this molecule, figuring out how we can make it better. So instead of having this cyclohexyl in group, we've done things like put these extended alkyl chains that can occupy some of this unused real estate in the RP65 active site. And whenever we couple that with introduction of fluoro groups on this central arrow ring, we can find compounds that are even more potent inhibitors compared to amixistat. This is kind of the crystal structure of this optimized compound. Okay, so going back to amixistat, this is a molecule, again, it's been studied very extensively in clinical trials. It's progressed all the way to phase 3. What was found through these clinical studies, I'll just kind of very quickly go through this, is that amixistat causes a prolonged dose-dependent suppression of ERG, and that this ERG suppression is mostly restricted to rods at the doses that were used in clinical studies. And importantly, it's reversible. And I'll just quickly show you this. So here's kind of the starting point. Again, these are just different doses of amixistat. We'll just focus on the 10 milligram. Here's the starting ERG B wave. Here is at day 14, so it's highly suppressed, but then at the study exit, it comes back to normal, so that's good. So it's sort of surrogate marker. In a surrogate marker sense, it worked very well. But whenever it was studied, again, in a phase 3 trial looking at geographic atrophy, unfortunately, it had no impact on lesion growth or change in best corrected visual acuity at doses up to 10 milligrams daily. So one kind of caveat, I think, to this clinical trial was that because amixistat has some significant visual side effects, the investigators had to kind of keep dropping the dose of this down over time. And it kind of raises the question of whether or not they had adequate suppression at this dose to be able to see an effect. Okay, I think it's still an outstanding question with this molecule.
problems that have occurred? I mean, literally, people could see suppression of their visual quality when you.
Yes. So, and Dr. Bernstein saw patients taking this molecule, so he might be able to elaborate more. But problems, I think the big one was problems with delayed dark adaptation, night blindness, chromatopsia, urethropsia. So visual distortions, that I think were problematic to people. And it's not only that they complained about it while they were on. I think it led to a lot of people dropping out of the trials because they were just like really concerned, I think, about these visual problems. Dr. Bernstein, you want to elaborate?
Yeah, these are, I mean, especially in geographic atrophy, these are people who don't see that well at night anyway.
Right.
And so when you give the dose and they're trying to get up, to go to the bathroom in the middle of the night, it's a big problem. Plus, the color vision problems are other things that it had more color vision problems than we would have expected going into this. They would see changes in color, and they just didn't like it. And so, yes, as Philip was saying, they would just keep dropping the dose. And so it's this trade-off. If you modulate the visual cycle, you have to do enough to actually affect the disease, or you're going to tolerate it.
You can't do so much that you're actually impacting the function.
Yeah, people don't like it at least.
That's a tough trade.
Well, I'll show you what we're trying to do to address that at the end of this. So, so this was a disappointment, but it's not stopped the development of amixostat. It's still being pursued for some other indications. So, of course, start with this one. It's still being studied in Stargardt disease. There's a trial ongoing for this. And it's also been studied in proliferative diabetic retinopathy. And I'm not going to go into the details of this, but more or less, the idea here is that if you modulate photoreceptor metabolism, that's impacting the vascular changes that are seen in diabetic patients, and it can possibly modulate it favorably. And that's been observed in animal models. Okay, so this is kind of the summary of the clinical trial status for all of these compounds. So fenretinide has kind of been abandoned as far as I know. Again, it made it to the end of phase 2, but didn't show efficacy there. Tinlarebant is, again, the most promising of the RBP4 antagonists. This is being developed by Belite Bio. Though it's in phase 3 trials for Stargardt disease as well as GA. Amixostat, which I just told you about, has been up to phase 3 trials in both AMD and Stargardt disease, and phase 2 in diabetic retinopathy. And then one that I didn't talk about at all, because it's not really a visual cycle modulator, but I just put it on here for completeness, is this molecule gilduretinol acetate, which has been known as ALK 001. This is deuterated vitamin A. And the idea behind this one is that those deuterium atoms are positioned so that they would disrupt the formation of bisretinoid. And so this is primarily has the most important application, I think, in Stargardt disease, and then possibly also GA. Now, if you look at, here's kind of efficacy metrics, but what I really want to point out with all of these visual cycle modulators, they all kind of suffer from the same issues: night blindness, visual disturbances, some reduced visual acuity, chromatopsia, xanthopsia. And again, it's very problematic for patients. And this is where the gilduretinol kind of shines, because it's not a visual cycle modulator. It's just it's more or less intervening in these sort of non-physiologic vitamin A transformations. And so that's good on one hand. On the other hand, it kind of has a little bit more limited, I guess, limited ability, I guess, to intervene in the various diseases where the visual cycle is implicated. But still potentially a promising therapy. Okay, so again, the roadblock for the clinical development of visual cycle modulators is really an excessively long duration of action, particularly for amixostat. This is just repeating what I've already shown you in humans, but even in mice, whenever you treat with amixostat and you look at the recovery of 11-cis retinal after a bleach, it's suppressed for days after a single dose. And the same thing in humans. This is day 2. You can see it at the highest doses was 70 milligrams daily. That again, the ERG function is really flatlined. And it's interesting that this is in spite of the fact that amixostat actually has a relatively modest serum elimination half-life in 4 to 6 hours. So the compound's gone after a day, but yet you still have this very prolonged, very severe ERG suppression persisting. So here's our idea on this. So amixistat again, this is kind of the base compound. And what we noticed is I'm going to kind of go back and forth between these. So we noticed that one thing that could be done here to potentially reduce the duration of action of amixistat would be to do some medicinal chemistry on this group. And this is something we hadn't done before. We mainly focused on this moiety, and this moiety. But if you have this ether group here, it's pretty straightforward to turn that into an ester. And esters are metabolically labile. And in fact, converting a starting molecule into an ester derivative is a concept in drug design called soft drug design, where you put, essentially you make a molecule that has a duration longer than you want, metabolically labeled, so that it will be metabolized and then cleared out faster than the starting compound. Okay, so we can make these metabolically labeled ester derivatives. And if we do that, again, they can be hydrolyzed by esterases to make inactive metabolites. Okay, so we did this. We took amixistat. This would be kind of the most closely related amixistat derivative and just made this into an ester. And then we also made 2 additional molecules. We call these I compounds, I001, 2, and 3, where we had changed this ester substituent to with the idea of controlling the accessibility of this group to hydrolysis. Okay, so potentially we could have molecules with varying durations of action. And I'll just skip right over to this graph, and this is actually demonstrating that this concept works. So whenever we compare it to amixistat, which isn't susceptible to hydrolysis at all, and it's basically a flat line, this is sort of percent test compound remaining after a period of time. You can see that these different molecules have different rates of degradation. And in fact, the amixistat derivative is degraded very quickly. And that, I don't know if this was pursued by Acucelo whenever they were doing their medicinal chemistry, but you can see just by changing amixistat, it actually makes a molecule that's too susceptible to hydrolysis. And you can modulate that by changing the identity of this group here. So that's good. We showed that these molecules are at least as potent in inhibiting RP65 in vitro, and they also are working in vivo. So this is a in vivo visual chromophore regeneration assay. This is kind of the baseline level of 11 cis-retinal before a bleach. We give amixistat and then bleach the animals and then allow them to recover. That recovery doesn't happen because we've really suppressed the visual cycle. And if we test this metabolite or I001, which again very quickly hydrolyzed, they don't have an impact on this regeneration, whereas I002 and I003 do. So that's good. They're working both in vitro and in vivo. And now the question, we confirmed this by crystallography. I won't go into this, but basically it's binding very similar to amixistat. But the question is, does this recovery happen at a reasonable rate? And that's what we're testing here. Again, looking at in vivo visual chromophore recovery after a photo bleach. This is the starting point. After a bleach, 4 hours, after giving amixistat 4 hours after a bleach, and you can see that there's hardly any visual chromophore recovery happen because of amixistat's strong inhibition, strong and prolonged inhibition. Whereas with I003 or I002, we're seeing a nice recovery of the visual chromophore at 4 hours. And the same thing can be said about the B wave amplitude recovery with I002. We see a nice recovery of this. So it seems that we have a molecule that is working like amixistat, but yet it's being cleared, and we can get back to our sort of normal state in a reasonable period of time, like within 24 hours. Not only does it suppress visual chromophore regeneration, but it's also protective against light-induced retinal damage. This is a vehicle. We're going to SLO images. Vehicle, you see extensive these autofluorescent puncta, which are protected against in the I002 or amixistat treated groups. It's protecting against the loss of photoreceptor outer segments by OCT, is shown here. And then if we look at the histology, we also observe the protective effect of I002 comparable to amixistat. Okay, so this kind of leads me to this last summary slide. This is how I think about the therapeutic window for visual cyclomodulation. So it's not as clear cut as what we normally think about in pharmacology textbooks, where you have your minimum effective concentration, you have your minimum toxic concentration, you're just trying to stay within that window. I would argue that this, as soon as you get to the minimum effective concentration, you start to have some degree of visual side effects. It's almost inevitable because of just this extension of the therapeutic effect. And it gets worse, obviously, if the concentration gets higher. But there's also a time factor to this, that if the molecule is working too long, again, as Paul mentioned, in the evening, people are they have to get up to use the bathroom, and they're relying on the rod vision, but it's completely wiped out. That's going to be a side effect. So that's the problem with a mixostat. You get into this window, but then it stays there too long, and then you run into this area where you really want the molecule to have stopped working, but it's not. Whereas with these soft visual cyclomodulators, we can get into this window and then come out of it before we enter this area where an individual might need to use their rod vision. So this is kind of our concept and why we think these soft visual cyclomodulators have greater potential for clinical development compared to a mixostat, because again, this has just been a molecule that's not very well accepted by patients. Good. So that was my last slide. I've got several people to thank. Postdoc in the lab, Dr. Marco Bassetto, who really drove forward that last data that I showed you with those ester derivatives. So he did most of that work in collaboration with Jianye Zhang. I want to thank Chris Palczewski, who's always providing really valuable feedback on this concept and kind of other things related to visual cyclomodulation. I want to thank our medicinal chemistry collaborators. So all of these molecules that we've studied were synthesized by Greg Toktrop's lab at Case Western. So I want to thank him, funding from the Department of Veterans Affairs and the National Eye Institute, and then RPB. And then finally, Synchrotron Facilities for allowing us to do our crystallography work there. Thank you for your attention. I'll be happy to take any questions.